Head and neck radiation, the role of the dental hygienist, is presented by Janet Aquilina Arnold, RDH.
Hello, my name is Janet Aquilina Arnold, and I've been a practicing dental hygienist since 1985. I've enjoyed a long career in a private dental practice in Burlington, Ontario, and presently I'm teaching at an accredited dental hygiene school in Ancaster, Ontario, while also practicing at a private dental hygiene clinic. For many years during my career, I practiced dental hygiene at a dental clinic at a major cancer center in Ontario. While I was at the hospital, my experiences there gave me an appreciation for the importance of the role of dental hygienists in providing oral health care for people who have or have had cancer, including head and neck radiation. Therefore, the title of this presentation is Dental Hygienists and Head and Neck Radiation, and the question is, what is our role as dental hygienists? My commitment to you. Although the opinions, thoughts, advice, etc. within this presentation are not the official policy of any institution, the information is evidence-based and based on my professional experience. In fact, you'll find that through the presentation, the topics are referenced and the numbers are indicated within the presentation, with a reference list found at the end of the presentation. There are no restrictions or third-party influence applied to this presentation, and although I do show specific products, it's very important to understand that these are merely examples of the products available in the marketplace. The learning outcomes for today's presentation are to increase confidence when providing dental hygiene care for clients who have had head and neck radiation, to apply the acquired knowledge to contribute to effective client care, to be an effective member of a multi-professional healthcare team, and to provide a starting point for further individual study. The role of the profession of dental hygiene. Medical care for people who have or have had cancer is truly multidisciplinary. A multidisciplinary approach to healthcare is a growing model within the Canadian healthcare system. Therefore, in the context of oral cancer, including care for people who have had head and neck radiation, this team includes oncologists, family physicians, nurses, dentists, and dental hygienists. While reviewing the literature, I didn't find specific references to the profession of dental hygiene in this context. However, as our profession and this model evolves, I suspect that we will see more dental hygiene specific references in this multidisciplinary context. All members of the healthcare team should be included in the consultative and collaborative process as we determine appropriate dental hygiene treatment for safe and effective dental hygiene care for people who have or have had cancer. We play a role in the prevention and management of the short and long-term side effects of head and neck radiation, and we contribute to the improved quality of life of the clients in our care. What contributes to quality of care includes pain management and function, including the ability to eat and speak comfortably. Radiation therapy, what is it? Radiation is one of the treatment modalities used to treat and cure head and neck cancer. It uses high-dose radiation to destroy cancer cells by damaging the genetic material within the cells. The result is the cells cannot grow or replicate. However, the radiation also damages normal cells. Whereas the normal cells can repair themselves, the cancer cells cannot. Therefore, the tumor is shrunk or destroyed, but also adverse side effects will be a result. Types of radiation therapy. There are two general types of radiation therapy: interstitial or brachytherapy, or external beam radiation or teletherapy. When radiation is delivered directly into the tumor, this is called interstitial radiation therapy. Radioactive pellets or seeds are placed into or near the tumor. The radioactivity dissipates over time, and the pellets are either removed or remain behind. An advanced technology for delivering external beam radiation is called Intensity-Modulating Radiation Therapy, or IMRT. This technology allows the beam of radiation to conform to the three-dimensional shape of the tumor, allowing a higher dose of radiation to be delivered to the tumor while sparing surrounding normal tissues, with a net result of reduced adverse side effects. The total dose of radiation is delivered in incremental doses over a defined period of time. For an incremental dose of radiation to be delivered with precision to the field of treatment, the client is fitted with a mask that locks the patient in place for the treatment interval. Oftentimes, people suffer from claustrophobia during the treatment, and they need to be sedated in order to receive it. Radiation oral side effects. Common side effects or sequelae of head and neck radiation include mucositis, dysgeusia, which is loss or change in taste, xerostomia, trismus, post-radiation caries, and osteoradionecrosis of the jaw. Mucositis is a short-term side effect of radiation and may be dose-limiting or cause the interruption of treatment. Such an interruption may lead to less than optimal treatment outcomes. Severity of the mucositis depends on the overall dose of radiation and the ability of the normal cells to repair themselves between incremental doses. In addition, oral microorganisms that may cause concurrent infection, such as bacterial or fungal infection, and smoking, aggravate the epithelial tissues that are damaged by radiation and may make the condition worse. The Multinational Association of Supportive Care in Cancer have made some recommendations for the management of oral mucositis, which may include interruption of therapy, the use of topical anesthetics such as viscous lidocaine, a mucositis rinse. Considerations with this rinse are that different oncologists often have their own recipes, and the recipes may include nystatin, lidocaine, and distilled water. The instructions for use are to swish and swallow the rinse, which numbs the back of the throat to allow people to eat comfortably. A consideration to be aware of is that the numbing of the throat may make people more prone to aspiration pneumonia because the back of the throat is numb. For pain management, systemic analgesics, including transdermal patches and narcotics, may be used. An additional consideration is the possibility of overlying bacterial, viral, and fungal infections. These infections must be identified, diagnosed, and treated separately. Oftentimes, a sodium bicarbonate rinse is prescribed. The recipe for this rinse is 1/2 teaspoon of baking soda, 1/2 teaspoon of salt mixed with 1 liter of water. And the instructions for use are to rinse with this solution several times during the day to provide relief. So our role as dental hygienists in the management of oral mucositis are truly multifaceted. We employ our dental hygiene process of care and all the components of ADPI to help prepare the client for their medical treatment. This may include periodontal assessment and debridement. Also, we act as advocates for our clients as they try to navigate through their treatment and cope with their diagnosis. We are part of the referral pathway within a holistic conceptual model of client-specific care. The next several side effects are considered long-term side effects. The first one that we'll be talking about is dysgeusia. Dysgeusia is a loss or change in taste. This occurs because the taste buds are very radiosensitive and are easily damaged by radiation. These changes may be partial or complete, and while the taste bud cells can regenerate, it is variable, and it is often age-dependent, and it may be a permanent change. So what are the implications of this for dental hygienists? Imagine our world which revolves around food for nutrition, and food as a very strong social association and part of our quality of life. Imagine that all food tastes the same. It all tastes like salt, or it all only tastes like blueberries, or has no taste at all. When we cannot taste foods, there may be a loss of appetite leading to nutritional concerns, including weight loss, weakness, malaise, and dehydration. In addition, and this can be a very serious side effect of dysgeusia, people who can't enjoy the taste of food suffer emotionally and may become very depressed. So what is our role? We can certainly provide emotional support and be someone that they can feel safe talking to. This is also a good opportunity to care for such a client from a multi-professional approach. It is in our scope of practice to make referrals and to consult with other healthcare professionals. Therefore, we can refer the client to a nutritionist or a dietitian to address nutritional concerns, to a physician to monitor and treat nutritional deficiencies and or issues surrounding depression, or to a psychologist or counselor to address emotional issues and depression, for example. A multi-professional approach may be what a client needs to attain optimal physical and psychological health. Complete and severe xerostomia. Severe or complete xerostomia can be a life-altering side effect. Radiation affects the salivary glands in the field of treatment. The parotid glands, which are the major salivary glands that produce serous or watery saliva, are very radiosensitive. As a result, if any saliva is produced, it tends to be thick, ropey, and sticky, and provides no comfort or relief from the symptoms of dry mouth. This degree of xerostomia that results from head and neck radiation causes a great deal of pain and discomfort, affecting a person's ability to eat because food will injure dry, delicate mucous membranes, and their ability to speak because without saliva, our tongues stick to teeth and our hard palates. In addition, sleeping patterns will be disrupted because of the discomfort caused by chronic dry mouth and a chronic lack of saliva. These activities become painful and severely affect quality of life. We do truly take our saliva for granted. IMRT radiation is intended to spare the parotid glands and to reduce the severity of radiation-induced xerostomia. However, this still remains a serious and long-term side effect for most head and neck radiation patients. Xerostomia and immunity. In addition to saliva playing an important role in eating, speaking, and general oral comfort, it also plays a role in our ability to fight infection. Saliva is part of our innate immune system, which is with us from birth. It provides a flushing action that will remove microbial debris and invaders from the oral cavity, as well as chemical protection in the form of immunoglobulins that target foreign antigens. So we are left with the question, are people with severe xerostomia at greater risk for infection, such as flu and colds? We should be cognizant of this possibility while we're providing care for our clients who have had head and neck radiation. Coping with xerostomia. So what can we do as dental hygienists to help afflicted people cope with this potentially debilitating side effect? We can counsel and educate them on coping strategies. The most important strategy is using plain water. Swishing and swallowing sips of water throughout the day is crucially important to maintaining their comfort and well-being. Another recommended strategy is the use of a systemic medication called pilocarpine hydrochloride, or Salogen. This medication stimulates glandular tissues, including salivary glands. However, many side effects are reported, including extreme sweating. That, along with debate on real or perceived improvement in salivary flow and comfort, makes some practitioners question the value of this medication. Synthetic saliva replacements and lubricating gels, such as Biotene products and Oral Balance gel, may or may not be beneficial, but are certainly worth trying. If a person gets relief from any of these products, either real or perceived relief, these products are truly worth their weight in gold. Post-radiation caries is another side effect that has long-term repercussions and can be extremely expensive to treat, causing socioeconomic struggles for clients that have had head and neck radiation. Saliva production is exponentially reduced during radiotherapy starting in the first week of treatment. Without the buffering capacity of saliva, the pH within the oral cavity declines, providing an ideal environment for the proliferation of Streptococcus mutans, the bacteria primarily responsible for dental caries. Colonization of strep mutans increases markedly during radiotherapy and remains high permanently. This gentleman displays classic results of post-radiation caries. Post-radiation caries is very aggressive and difficult to treat. It decays the teeth around the circumference along the gingival margin and can completely blow out the occlusal surfaces of the teeth. In addition, proximal caries in this context is not usually found at the contact point, which is typically where interproximal caries is found. This classic radiographic evidence of post-radiation caries has the appearance of large bites that have been taken out of the sides of the teeth up onto the roots apical to the contact points, extending subgingivally. Post-radiation caries is really a totally different caries animal than what we're used to seeing typically in practice. Therefore, our role is in the prevention of this destructive and potentially painful and certainly very expensive side effect. It can become a truly serious economical challenge for people already challenged financially by a very serious long-term illness. Client education surrounding the causes of post-radiation caries, the need for exemplary oral self-care, including recommendations and demonstrations of brushing, flossing, and the use of any other oral health care aid deemed appropriate and client-specific, nutrition counseling related to minimizing dietary sucrose is absolutely vital in this context. Prevention and treatment requires a close collaboration between dentists and dental hygienists. We are particularly well suited for education and interventions related to the use of topical anti-cariogenic agents. The use of a daily 1% neutral sodium fluoride gel application appears to be part of the foundation of preventing post-radiation caries. The gel is applied to the teeth in a custom-made fluoride tray. The method of fabricating the trays is similar to that of athletic mouth guards. The interproximal surfaces and undercuts on the model are filled in with a slurry of plaster, and the trays are trimmed to about 2 millimeters beyond the gingival margin to ensure a proper fit. The instructions to the clients must be very clear. Also, over the long term, clients often need a lot of encouragement to ensure their compliance. The instructions are as follows. Topical fluoride should be applied every day forever. This is really quite an important detail to ensure that you explain to your clients. In the custom trays, instruct them to dispense a ribbon of fluoride gel, spread it evenly in the tray with a Q-tip, with instructions to not overfill the tray. If they put fluoride in the trays and they put them over their teeth and the fluoride spills out into their mouth, they've overfilled the trays and they should be instructed to put less fluoride into the trays. They should wear the trays with the fluoride inside of them for 5 minutes, either one at a time or together, depending on their comfort level. After removing the trays, after 5 minutes, the client should be instructed to expectorate the residual fluoride, and with instructions from refraining from eating, drinking, or rinsing for at least 1 hour afterwards, and preferably overnight. More recently, evidence is supporting newer approaches to prevention. The evidence has shown that the use of topical amorphous or bioavailable calcium and phosphate helps to remineralize teeth affected by xerostomia-induced decalcification. In addition, it has also been shown that amorphous calcium and phosphate complements the effects of fluoride, resulting in an augmented benefit. Therefore, using both topical fluoride applications and calcium and phosphate paste will make both work synergistically and better together. One example of amorphous calcium phosphate is MI Paste by GC America. One word of caution is that this is a milk-based product, so clients who have milk allergies should not be using this paste. Another similar example is X-Pure by Oral Science. This formulation is slightly different, however. It is a calcium-sodium phosphosilicate, but its effect is similar to the Recaldent in MI Paste. An additional reported benefit is that it neutralizes the oral pH. For home use, it has been recommended that the paste be applied in a custom tray and apply to the teeth for 5 minutes. Remove the trays and expectorate the residual, allowing the residual to remain on the teeth for half an hour or overnight. Alternatively, in my experience, I've had clients brush these pastes on their teeth for 5 minutes and then expectorate the residual. Remember to instruct your clients to not rinse their teeth afterwards, and they can actually use these pastes as a replacement for their regular dentifrice to save a step in their daily routine. Another strategy to control post-radiation caries is the topical application of fluoride and chlorhexidine varnishes, such as Enamel Pro Varnish by Premier, 3M SB Vanish Fluoride Varnish, or Prevora Chlorhexidine Varnish. All three of these products have shown promise in the prevention of post-radiation caries. Finally, the use of xylitol products in the form of gum or mints has become another strategy in caries prevention. When clients receive the proper pre- and post-radiation oral care, along with adequate education, inspiration, motivation, dedication from both themselves and their dental hygienist, and compliance, they can certainly maintain long-term oral health. Trismus. Trismus is defined as a limited jaw opening, which is caused by scar tissue that becomes more fibrotic and less flexible over time due to damage from the radiation. Trismus will affect quality of life, and what I mean by that is that if a person can only open 1 centimeter, for example, there is difficulty eating normally and they may be on a liquid diet. They may have difficulty brushing and flossing. Certainly restoring decayed teeth may be difficult and if not impossible. And in addition, debridement of plaque biofilm and calculus may be difficult if not impossible. The net result can be catastrophic. For example, one of my clients who suffered from extreme trismus had to have all her molars extracted due to post-radiation caries. In order to accomplish this, the surgeons had to remove her right mandible in order to access the teeth for extraction, and they rebuilt her jaw with a bone graft and a titanium fixation plate. In my personal clinical experience, it was very common for people to be able to open just 1/2 to 1 centimeter. So imagine trying to live your life, receive oral health care with such a restriction. Very, very challenging. Therefore, in order to prevent trismus, various stretching exercises are recommended. For example, stacking tongue depressors are useful, as are the use of commercial stretching devices, which may be recommended. Osteoradionecrosis. Osteoradionecrosis is a very serious complication. The bone cells and vascularity are irreversibly injured due to the radiation, and healing potential is severely decreased. Osteoradionecrosis may develop spontaneously, and the risk continues indefinitely. This may be a good question for a medical history review. Have you ever had head and neck radiation? Active periodontal disease and poor oral hygiene are considered risk and predisposing factors, as is trauma, such as extractions. Therefore, clients should be advised to avoid the need for extractions, if at all possible, making their oral self-care and maintaining good oral health extremely important. Osteoradionecrosis can be progressive and lead to pathological fractures, which could lead to more serious treatments for this condition. This condition is sometimes treated with hyperbaric oxygen, or the jaw itself may be needed to be resected and rebuilt with a bone graft and fixation plates. Therefore, our role is educational in terms of educating the client on maintaining excellent oral health, preventive in terms of preventing radiation caries and teaching them excellent oral self-care techniques, and also therapeutic in nature in terms of periodontal health assessments and periodontal debridements. This picture is an example of what osteoradionecrosis might look like. It appears as exposed bone which may be loose. A common anatomic location to find this is on the lingual of the mandibular molars. Therefore, a dental hygienist's role for people who have had head and neck radiation is as a member of a multi-professional team. Before radiation, our role is in the periodontal assessment and debridement to prepare them for their treatment. We play a role in counseling our clients related to the management of resulting sequelae. During treatment, we're part of the referral pathway for pain management, and we can certainly provide emotional support during their journey. After treatment, management and prevention of long-term side effects of head and neck radiation within the dental hygiene process of care, or ADPI, within our scopes of practice, and following our codes of ethics is crucial for long-term oral and overall health of our clients affected by head and neck radiation. As we end this presentation, I would like to once again have you take note that the specific products that I've mentioned in this presentation are merely examples of the choices of products that are on the market. In addition, this presentation is intended to be a starting point in your continued search for information on this topic. Additionally, I have provided references included in this presentation for you to refer to if you wish to look up more information on this topic. Thank you very much.
Head and neck radiation, the role of the dental hygienist, has been presented by Janet Aquilina Arnold, RDH.